Now, is a new therapy like ARNI beneficial in HFrEF patients with borderline systolic blood pressure? Yes, of course. So, when you look at these patients, the event rate of a patient not receiving ARNI is very, very high as compared to an ACE inhibitor. So, if you compare head to head an ACE inhibitor and an ARNI, you'll find that using an ARNI and the other three pillars of heart failure treatment, you are adding around 8 years of quality free, event free cardiovascular, event free survival for these patients for a 55-year individual. So, if you're able to even give a 50 milligram BID dose for these patients, I would say go for it. Now, there are certain episodes of hypotension which could occur in these patients, but very, very rarely do you have deaths due to hypotension because of ARNI. And how do we manage a patient who has hypotension with ARNI? The first thing is correct the volume or salt depletion prior to the administration of ARNI and start sacubitril valsartan at the lower dose. In hypovolemia patients, the dose of diuretics is likely to be down titrated, especially when you are having a very, very higher dose of diuretics to start with. So, we should start down titrating your diuretics as soon as possible. In fragile patients, elderly patients, start with ARNI at a lower dose because they will have a low systolic blood pressure of around 100. And in these patients, you should be very, very careful in starting an ARNI at a lower dose. And if a patient has got, is naive to ACE inhibitor or ARB, again start on a lower dose of ARNI or 50 milligram BID. Sometimes even 25 milligram BID can be started and then up titrate slowly within a week or 2 weeks so that you're able to reach an achievable target. And then, similar to the other dose, sometimes a maximal dose of ARNI, like what we are targeting, 100 mg, 200 mg, may not be tolerable to all patients. So, we don't need to achieve all that, but at least keep a 50 milligram or a tolerable dose of ARNI on board.